Good afternoon, everyone. Thanks for joining us. We'll be starting our session in a few minutes. So until people join the sessions, let's start with an introductory session about Yetena Weg. So to say a few things about Yetena Weg, Yetena Weg is a non-profit organization that is registered in Pennsylvania, and it's run entirely by volunteers. Currently, we have over 70 active members from 5 different countries, and our numbers continue to grow each day. And the image on the top right corner, you see it highlights one of the volunteer get-togethers where we can capture the spirit of our team. So to talk a little bit about the projects and engagements of Yetena Weg, we can divide it into 4 key areas. The first is the health promotion project, which we achieved through discussions and articles focused on public health policy, and its implementation both locally and globally. Next is the community engagement, where we organize blood drives, inclusivity and equity projects and fundraising campaigns. Our third and most impactful initiative is mentorship and skill sharing. This one, it involves direct mentorship and hosting of webinars on soft skills, career development, and professional growth for health professionals. And lastly, we have the medical education project, which includes our continuing medical education programs, as well as research and quality improvement initiatives. So Yetena Weg is more than a digital platform. It provides a platform where many volunteers can come together and make meaningful impacts. Another key project we have is the Yetena Weg Roha Research Fellowship Program. It had 2 phases. The first phase of this fellowship, it was launched in collaboration with the Kurambas Specialized Hospital on March 14th, 2023, and it involved 3 departments, which were the oncology, radiology, and internal medicine. So research grants were awarded to the top 4 participants, while mentorship was provided for the next 10 winners. And the second phase of this fellowship was organized in collaboration with St. Paul Hospital Millennium Medical College. Specifically, it was targeting the medical interns. And again, research grants were awarded to 4 winners who have already been announced. So to say a few things about our CME team, we have held over 39 CME sessions in the year 2024. And so they are freely accessible, and they are conducted in partnership with the Ethiopian Medical Association, Ethiopian Society of Cardiac Professionals, and Ethiopian Society of Internal Medicine to provide continuous training for healthcare professionals. As I said earlier, we hosted about 39 CME webinars in the year 2024, featuring renowned local and international speakers for each session. And they attract an average of around 150 to 200 healthcare professionals on each session. So for the year 2025, we have planned to organize over 30 webinars covering a wide range of topics, including emergency medicine, surgical cases, as well as medical cases, and many more. So if you're asking where you can access our previous CME sessions, you can access our sessions by going to our YouTube channel. All videos will be posted on the YouTube channel, so you can freely access them. And also you can stay updated on our upcoming CME sessions by joining Yetena Weg's Telegram channel for healthcare professionals, and also following our social media posts. The links will be shared in the chat box shortly after the webinar has started. And to ensure that you have the best experience during the webinar, we encourage that you send your questions to the Q&A and or to the chat box. And at the end of the webinar, your questions will be addressed by our guest speaker accordingly. And to get CEU certificates, you must fulfill the following sets of criteria, which is the first is to attend the whole session virtually, because the minutes attended will be checked by the Zoom attendee reports. The second is to fill the Google form for personal details and attendances. Please make sure that the credentials you provide are correct, as they will directly be put on your CEU certificates. The third is you must be able to score 50% and above on the post-webinar quiz. You'll be able to see your results right away, but the process of issuing certificates will take up to 2 weeks to be delivered on your email. So in the meantime, we ask that you wait for us patiently. And the post-CME quiz link will also be posted in the chat box as well as on the dedicated Telegram group that we've created for this specific webinar. So we urge everyone to join this Telegram group to be able to access the quiz link. We'll share the link for the Telegram channel shortly as well. So thank you very much. Before we proceed to today's webinar on pediatric diarrheal illnesses, let me briefly introduce our guest speaker. So today's guest speaker is Dr. Ahmed Ibrahim, who has earned his Doctor of Medicine degree from Hayat Hospital Medical College and later specialized in pediatric and child health at St. Paul's Hospital Millennium Medical College. So Dr. Ahmed has held key clinical and leadership roles, including serving as a pediatrician at Afran Hospital and Pediatric Clinic and as an assistant medical director and trainer at Hayat Hospital Medical College. Currently, he is the CEO and founder of Ra'ayat's Pediatric Specialty Clinic, where he leads pediatric care initiatives. With a strong background in neonatal health, Dr. Ahmed has worked as a trainer for nurses on common neonatal diseases and has served as a teaching chief during his residency. So without a further ado, let me leave the floor for our guest speaker for today, Dr. Ahmed. Doctor, you have the floor.
So our topic today is, I'll try to say a little about pediatric diarrhea as a whole. It's a very large topic, as we all know, so I'll try and make it as simple as possible. I'll try to condense it. Okay, so starting from introduction, diarrhea is best defined as excessive loss of fluid and electrolytes in the stool. We can use the timeline to bring it into three. One is acute diarrhea, which is less than 14 days. It is sudden onset. And because it's pediatrics, we cannot generalize all. So we say excessive loss of 10 ml per kg per day in infants and greater than 200 gram per 24 hour in older children. The second one is if it's prolonged, which is from 17 to 13 days. And then we say the third type of diarrhea is persistent diarrhea, which is 14 days or longer, or we can also call it chronic diarrhea. So coming to the epidemiology, diarrhea is the second leading cause of death in children under 5 years old. It accounts for approximately 525,000 deaths annually, and most occur in low and middle income countries like our own. So what are the mortality? What are the killers in children? Number one is pneumonia with 33%. And as you can see, diarrhea accounts for the second being 19%, followed by neonatal sepsis, malaria, and the like. So this is still a large burden. And this is why we thought to present you this topic. So what is the burden? As I was trying to tell you, it's almost 1 billion episodes of diarrhea per year are there, and mostly it's in Africa and South Asia. Africa accounting for 63% of the cases globally. But the good thing is there's a decrease in 10% of mortality in the past decade, and this is due to rotavirus vaccination, improved case management, ORS use, and improved nutritional management. Coming to the case in our country, this is a research I found, which is random. Took a lot of meta-analysis, and as you can see, male accounts for 19%, female accounts for 90% of diarrheal cases, and 6 months to 11 months accounts for highest 25.3 and 25.4, with 12 to 23 months also the highest. And by region, as you can see, the highest is in Gambela, then Dredoa, and then Tigray regions, and then South nations are also highly affected with 24%. So what are the risk factors? As you all know, poor sanitation is one, lack of clean water, as I mentioned, vaccination, especially the rotavirus, immunodeficiencies like AIDS, HIV, malnutrition, increase the risk of diarrhea and even increase the risk of associated mortality. So malnutrition treatment is very important. Linked with this also, moderate to severe stunting increase the odds of diarrhea associated mortality as well. Measles also the same, is a risk factor for diarrhea, and lack of exclusive breastfeeding for the first 6 months is a high risk, and inadequate health care access. So when we say malnutrition, there's also micronutrient deficiencies, right? And vitamin A deficiency accounts for 157,000 deaths from diarrhea, measles, and malaria. And zinc deficiency is also estimated to cause 116,000 deaths from diarrhea and pneumonia. So now it's mandatory to give zinc and in diarrhea as well as pneumonia. As a treatment, we have the best treatment now is antibiotics plus zinc, even for pneumonia, because zinc deficiency, as you saw here, has higher mortality. And as you know, vitamin A is given every 6 months up to 5 years. We give 200,000 international units as a type of vaccination in our country. So there was a study for risk factors in our country, and the commonest risk factors are age of the child, which is worse when they're less than 5 years old, source of drinking water, if it's sanitary or not, if they have health insurance or not, the place of delivery, if it's in the hospital or not, family size. As the family size increases, the chance of diarrhea increase, water storage, how they store water, liquid waste disposal, and vaccination were significantly associated with diarrhea among under 5 children. And the authors concluded that interventions targeting improvements in drinking water sources, health insurance coverage, sanitation practices, and vaccination rates are crucial for mitigating the impact of diarrheal disease among children under 5 years in Awi zone. This research was done in Awi zone. So another risk factor is daycare or childcare. So they have children attending daycares have 2 to 3 times higher risk of having diarrhea and also outbreaks. Some of the causes are enteric virus like calcivirus, parasites like Giardia lamblia, Cryptosporidium, bacteria like Shigella and E. coli, and hepatitis A outbreaks can start at the daycare and even spread to the community, and especially in diaper-wearing children. When they change the diaper, the daycare attendants, they can take it out to the community and cause outbreaks. But the commonest etiologies, if the parents come to us and say, this patient is in daycare, we have to think of Giardia lamblia and norovirus are the commonest because they have low infectivity dose and they have asymptomatic excretion from other children. So what are the etiologies? We can broadly classify them to 2. One is infectious cause, like viral, like rotavirus, still the most common even with vaccination. Norovirus is close second, then adenovirus, and bacteria like E. coli, Salmonella, Shigella, Campylobacter, and Bacillus cereus are there. Parasites as Giardia, Cryptosporidium, Cyclosporia, and Entamoeba histolytic are there. Non-infectious causes are very broad. Some of the common ones are food intolerance, antibiotic-associated diarrhea, inflammatory bowel diseases. There are also genetic causes, hyperthyroidism, and like cancers. It's a lot of etiologies that are non-infectious. So when we come to etiology of infectious diarrhea based on age, as you can see here, the first year is commonest is still rotavirus. This is taken from Nelson 22nd edition, which came out in 2024, followed by Cryptosporidium, then Salmonella typhi, and then it goes down. So 12 to 23 months is commonest still rotavirus with Shigella and Cryptosporidium following. There's also cholera, vibrio cholera, and then when we reach to 2 years to 6 years, Shigella species becomes the most common, with rotavirus and C. jejuni and cholera following. Etiology in low-cost areas, the 4 most common are rotavirus, cryptosporidism, Shigella, and enterotoxin producing E. coli. And the 3 agents associated with most deaths among children under 5 years is rotavirus, Cryptosporidium, and Shigella. So when we come to the pathogenesis, a young infant has approximately 5 ml per kg per day of stool output. The volume increases to 100 grams when they become an adult. The greatest volume of intestinal water is absorbed in the small bowel. In an adult, 10 to 11 liters per day can be absorbed in the small intestine, whereas the colon absorbs only 0.5. So if the pathology is in the small bowel, there will be voluminous diarrhea with a watery type. But when they're in colon pathologies, it produces lower volume of diarrhea. So there are 4 types of pathogenesis, and secretory is the first, osmotic the second, motility abnormalities, and combination. The combination is the commonest. Mostly it's not one type of pathogenesis to one diarrhea. They have multiple types. So coming to one of the primary mechanism, secretory, the defect is in decreased absorption and increased secretion and electrolyte transport. When we see the stool, it's watery with normal osmolality with ion gap of less than 100. Common examples are cholera, toxigenic E. coli, carcinoids, tumors like VIP neuroblastoma, congenital chloride diarrhea, Clostridium difficile, and Cryptosporidium, especially in AIDS patients. And this, if we put them in fasting, the diarrhea still continues. There will be bile malabsorption and can also increase intestinal water secretion. So in the stool exam, we will find no stool leukocytes. The second is osmotic type, and the defect is in mild digestion, and there will be transport defect of ingestion of unabsorbable substances, and the stool will be watery, acidic, and reducing substances will be there, and there will be increased osmolality. So some examples of the pathology are lactase deficiency, glucose galactose malabsorption, and laxative abuse. So when this diarrhea stops with fasting, unlike the previous one, and it has increased breath hydrogen with carbohydrate malabsorption and no stool leukocytes. The other one is increased motility, and the defect is in decreased transit time. They will have loose to normal appearing stool and is stimulated by gastrocolic reflex. The example of diseases are like IBD, irritable bowel syndrome, thyrotoxicosis, post-vagatomy dumping syndrome, and infections can also contribute to these increased motilities. So the next one is decreased motility. This is mostly defect in neuromuscular units and stasis, leading to bacterial overgrowth. Then they will have loose to normal appearing stool. They will have pseudo obstruction type, and blind loops are example of the disease, and the comment is possible bacterial overgrowth. The other primary mechanism is decreased surface area or osmotic motility. This is the defect of decreased functional capacity. They will have watery stool. The examples are short bowel syndrome, celiac disease, rotavirus enteritis, and this might require elemental diet plus parenteral alimentation to treat these patients. The other primary mechanism is mucosal invasion. This leads to inflammation, decreased colonic reabsorption, increased motility. In stool exam, we'll get RBCs, increased WBCs. These examples are mostly bacterial with Salmonella Shigella infection, and the commonest parasite being amoebiasis. Yersinia Campylobacter infections is also there. They have dysentery, which is evident with blood mucus and WBC in stool examination. So when we come to the pathogens of specifically infectious diarrhea, the enteropathogens that are infectious in small inoculi like Shigella, STEC, norovirus, rotavirus, Giardia intestinalis, and Cryptosporidium C. difficile, Amoeba histolytica are readily transmitted from person to person via fecal to oral route. But pathogens with larger infectious doses such as cholera, NTS, ETEC, and Campylobacter generally require large amounts and generally require food or water vehicles to cause the infection. And pathogens that produce preformed toxins like Staph aureus have shorter incubation times, like 1 to 6 hours, compared with 8 to 16 hours for those that must elaborate enterotoxin in situ, like C. perfringens and Bacillus ceres enterotoxins. When we come to the pathogenesis of viruses, they have cytolytic infection of small intestine and the villus tips, resulting in decreased absorption, as well as disaccharide malabsorption, as well as inflammation and cytokine activation. As I told you, this in the pathogenesis, these have multiple ways of causing diarrhea. As the commonest is the rotavirus. The rotavirus protein called NSP4 acts as a viral enterotoxin that produces secretory diarrhea. It also activates enteric nervous system, causing decreased gastric emptying and increased intestinal motility. And there is also genetic susceptibility to this virus, the rotavirus and noroviruses. Researchers have shown that O blood groups have higher risk of having severe diarrhea, but B blood group is protective, and there are also cell surface genes like FUT2 and 3 gene mutations that cause severe diarrhea in patients. So what are the clinical presentations other than diarrhea? They will have vomiting, fever, dysentery when it's frequent small stools, but containing blood, but bloody diarrhea is when it's large volume with decreased systemic illness. They will have steatorrhea in malabsorption syndromes like lactose intolerance. We have to ask also if there's antibiotic history, if it's antibiotic-related diarrhea. Nutritional status, as I told you, we have to know if they have malnutrition, stunting, and the like. HIV status and atopic history, especially atopic history in cow's milk colitis and cow's milk allergy. So other clinical presentations are, if it's a persistent or chronic diarrhea, we have to think of common etiologies like cryptosporidism, Giardia lamblia, Cyclospora, amoeba, entamoeba histolytica, non-typhoidal Salmonella, Yersinia, and Campylobacter. Like visible blood in the stool, Shigella, Salmonella. I will not bore you with all this. We'll share the slides, so I'll tell you only the commonest. If they have fever, mostly high fever will be in bacteria, low fever in virus, and there's also high fever in entamoeba histolytica, so we have to keep that in mind. Abdominal pain is mostly in bacteria like TEC and Campylobacter Yersinia, and we might even see severe abdominal pain with Yersinia. Persistent abdominal pain and fever is in Yersinia enterocolitica and Yersinia pseudotuberculosis. This is very important because it may mimic appendicitis. We have had a lot of cases where we think it's appendicitis, but ultrasound again and again is normal. But when we give them ceftriaxone, when we admit them and hydrate them and everything, with the ceftriaxone, it improves. So this is pseudoappendicitis due to Yersinia enterocolitica and Yersinia pseudotuberculosis. There might also be nausea and vomiting due to Staph aureus enterotoxins. Diarrhea and abdominal cramping might be there, vomiting and non-bloody diarrhea and norovirus, and chronic watery diarrhea with post-infectious irritable bowel syndromes. So what are the differential diagnoses to diarrhea? How do we limit our differential diagnosis? One is by age. We say, is it infant, child, and adolescent, like every pediatric case. So in infant, then we go to acute. If it's acute, AG is the commonest one. For the first one, etiology is viral, followed by bacterial, then protozoal infections. Then there might be sepsis and systemic infections, antibiotic-associated diarrhea, and then overfeeding. For children, the commonest type of acute is again AGE, food poisoning, systemic infection, and antibiotic-associated diarrhea. Adolescent is the same. Rare causes in infants like primary disaccharide deficiency, Hirschsprung disease, and the like. Rare diseases in the child like toxic injection, hemolytic uremic syndrome, intussusception. especially if they have bloody stool, we have to dysentery. So if they have dysentery or bloody stool, we have to check for intussusception. When we come to adolescents, we have to rule out hyperthyroidism and appendicitis and check for other signs like that. Coming to the chronic diarrhea, the common ones in infants is post-infectious secondary lactase deficiency. This happens after we treat them for bacterial illness with antibiotics, but their GI doesn't respond fast and heal fast. So there will be a transient lactase deficiency and diarrhea after that. Another common case is cow's milk or soy protein allergy. Another is chronic non-specific diarrhea of infancy. Excessive fruit juice also, if they give them in bottle and they drink a lot of juice, the sorbitol in it, the sugar, acts like a osmotic type, and then they will have diarrhea. Others are celiac disease, cystic fibrosis, and AIDS defining. When we come to children, it's the same like post-infectious secondary lactase deficiency is there, IBD is there, celiac disease, cystic fibrosis, lactose intolerance, and then again, you have to check how much fruit juice, how many ml they drink. Giardiasis, IBD, and AIDS is there. In adolescence, the first commonest is IBD as a differential after AGE. Then IBD, lactose intolerance, giardiasis, laxative, and constipation with encopresis. Constipation with encopresis is when they hold their stool for a long time and then it just releases. So the rare causes of constipation are mostly primary immune deficiency in infants, like there will be IPEX-like syndrome, glucose galactose malabsorptions. In children, there will be primary and acquired immunodeficiency, then secretory tumors, pseudo-obstruction, and more in adolescents also there will be secretory tumors, primary bowel tumors, and parasitic infections like Giardia is common chronic cause. So as you saw, we have to have high index of suspicion for giardiasis, appendiceal abscesses there, and Addison's disease. So coming to laboratory evaluation, we start from the most common and the cheapest one, which is the stool exam. But this is time consuming and lacks sensitivity, in part because shedding can be intermittent. Especially in amoebiasis, we might have a lot of false negatives. So we have to analyze 3 specimens from separate days to say it's normal or not. There are new technologies which are rapid tests called molecular methods, and you just put the stool, you just drip it on the stick and it tells you is it bacterial, viral, or protozoan. So stool, we can also see the stool for mucus, blood, neutrophils, parasites, and bacteria, and the finding of more than 5 leukocytes per high power field shows us it's more likely bacterial. As I was telling you, STEC and Entamoeba histolytica is mostly normal. So it will not rule out, if you see just one stool result normal, it does not rule out amoebiasis. So norovirus also has a PCR type of test, but it's not available in our country. The second laboratory test is culture, but it's costly, so we don't do it for all of them. The indications are if they have moderate or severe disease, if they are immunocompromised, if there's outbreaks, especially suspected hemolytic uremic syndrome, or have highly suggestive epidemiologic history. And the stool specimen needs to be transported and plated quickly, and it should be transported in special transport media. And if the child has not passed stool, but you want to give antibiotics because the patient is becoming critical, what we do is put a rectal swab inside the rectum and then put it directly into the transport media. So another one is stool anion gap. There are some specialized hospitals that actually do this, especially if there's a gastroenterologist there. So it's available in this country, but in specialized places. So this is the calculation, and we mostly what we check is if it's above 100 or below 50. If it's above 100 is derived from ingested or non-absorbed osmotically active solute or non-measured ions. In contrast, a low gap is typically observed in secretory diarrhea. So the next one is for serum electrolytes. Mostly diarrhea is isonatremic. So for all cases, we don't do serum electrolytes, but some indications are if the patient has severe dehydration, he might have, or they might have hyponatremia or hypokalemia. So we have to check for that. If they're taking IV fluids as well, if our treatment is working or not, we have to check. And when there is a history of frequent watery stools, yet the skin pinches doughy, which suggests hypernatremia, hypernatremic dehydration, we have to check. Then when inappropriate rehydration fluids have been administered in ATO, we have to check if they, for example, they gave them juices instead of ORS, we have to check if they have hyponatremia or hypokalemia as well. So another differential is congenital chloride diarrhea, which is a gene defect on SLC26A3. We check the stool for chloride. There are machines, stool legs, serum electrolyte machines. You can tell them, are you testing blood or stool? Some of them have like that. So if you check the stool and it's greater than 90 millimeter per liter of more, and then you see the serum electrolyte has hyponatremia, it's congenitally acquired disease. So if you suspect hemolytic uremic syndrome and the patients have PTK and the like, we will have a complete blood count showing anemia, which will be seen with high platelets with thrombocytopenia, with serum electrolytes with hyperkalemia because of renal failure, and we'll also check renal function tests. So we can also do blood culture with the indications being if the infant has or child has fever with blood in the stool and who's younger than 3 months. If all of this, or if they have persistent fever and they're a child, we do blood culture. If they're immunocompromised, we do blood culture. And if they have hemolytic anemia or other risk factors also, we have to check for etiologies. So the other one is endoscopy and biopsy. As I told you, since the diagnosis is very large, you might do endoscopy and biopsy to see what is actually causing it. There are new types of endoscopy, which are capsules, and we can use it for more than 10 kg weighing children. One of them is called Smart Pill. It checks for pH sensors. It has its own battery antenna. It has temperature sensors, pressure sensors, and it checks the motility of the GI, and it narrows your differential diagnosis. More than this, there are also more expensive endoscopies that have cameras at the top. So when we come to management, the most important management is the hydration, because the highest risk of the reason that they die is due to dehydration and electrolyte abnormalities. So we have to replace that. So how do we rehydrate? We rehydrate with ORS plus replacement therapy for the ongoing loss. We have to continue breastfeeding and refeeding with an age-appropriate diet. But first, when we treat the dehydration, we have to check, is it severe or some dehydration? Severe dehydration, if they have 2 or more of these, like lethargy, unconsciousness, sunken eyes, unable to drink or drinks poorly, and skin pinch goes back very slowly, which is more than 2 seconds, we categorize them in severe dehydration. If they have 2 or more of the following with restlessness, irritability, sunken eyes, drinks eagerly, and they're very thirsty when you see them, and skin pinch goes back slowly, they have some dehydration. So once we categorize them, if they have some dehydration, both infants and children get ORS 75 ml per kg. For example, if the child is 10, it means he will receive 750 ml over 3 to 4 hours. then we continue breastfeeding. After the 4 hours, we can give food if the child is more than 6 months old and taking solid foods. But after that, we have to always think about replacement of the loss, which is if less than 2 years old, we give 50 to 100 ml per vomit or per diarrhea, per loss. If they're greater than 2 years, equal to or greater than 2 years old, we give 100 to 200 ml ORS. If they have severe dehydration, we have to check their malnutrition status, their nutritional status. So if they are malnourished, we have to give small bolus like 5 to 10 ml per kg, and we have to also give them Resomal, their own type of fluids. But if they are not malnourished, for infants, we give 20 to 30 ml per kg within 1 hour, and then the rest 70 ml per kg over 5 hours. If they're more than 1 year old, we give it the first bolus 20 to 30 ml per kg within 30 minutes, and then the rest within 2 hours. So the age matters. And for replacement therapy, again, we give them 50 to 100 ml ORS if they're less than 10 kg, but if they're greater than 10 kg, we give them 100 to 200 ml. So when we come to management of chronic or persistent diarrhea, we can follow this flow chart, which is in Nelson. So this diarrhea is greater than 14 days without severe malnutrition. We have to assess them, resuscitate, and early stabilize them with IV or ORS. Then we treat the electrolyte imbalance because it's chronic. They might have electrolyte imbalance. Then we screen and treat for systemic infections. Treat the persistent diarrhea with blood in the stool with an oral antibiotic effective against Shigella, because Shigella gives you dysentery. And then we have to continue breastfeeding and reduce lactose load, because lactose in chronic diarrhea might worsen the diarrhea. And then we give milk cereal or replace milk with yogurt because it has less lactose in it. And we also have to treat the micronutrient deficiencies with giving zinc, vitamin A, and folate. If they recover, we just follow up for growth. But if they have continued and recurrent diarrhea, we have to investigate for infections and to give second-line dietary therapy, continues with diarrhea and continued diarrhea and dehydration treatment. And we have to reinvestigate for intractable diarrhea of infancy. We have to check if they have lactase deficiency, galactase deficiency, and we have to think about giardiasis and the things that cause the chronic diarrhea, as I showed you. This is one diet management. We reduce the milk concentration to make it low lactose diet, and we use this like rice, vegetable oil, cane sugar, and this to mix it. It's just for your general information. And this is if they still have persistent diarrhea, we do it with no milk, and we do it with whole egg, rice, vegetable oil, glucose, and water to make 200 ml like formula, which is lactose free. So one of major supplementations in the micronutrient is zinc supplementation. In India, they even have a research arm in a university called just researching zinc. So zinc is very important. If you ask why is it important, it reduces all-cause mortality by 46%, which is very high. Just to give zinc and save almost 50% of children. It also reduces hospital admission by 23%. It leads to increased use of ORS and reduces inappropriate use of antimicrobials. It reduces recurrence of diarrhea for the next 2 to 3 months. So all children older than 6 months of age, what we give them with acute or chronic diarrhea is 20 milligram per kg per day, 10 to 14 days. And if it's chronic, we can continue the zinc. The mechanism of action is it promotes both enterocyte growth and ion absorption, meaning it promotes healing of the GI and promotes immunity of the children. So another management is ondansetron. It reduces the incidence of emesis or vomiting, thus permitting more effective oral rehydration. And it's well established in emergency management of AGE in children. Ondansetron is the best antiemetic we have. It's readily available in this country. It also reduced IV fluid requirement and hospitalization. And what we have preparation in this country is we have the IV, the syrup, and the tablet. And the dosage is 0.1 milligram per kg, PRN or TID, looking at if they improve or not. Coming to antibiotic therapy, we have to be judicious while using it. There are several factors why. The first one is most of episodes of AG are self-limited among otherwise healthy and nutritionally well children. Second is the increasing prevalence of antibiotic resistance has prompted restricted use of these drugs. So at least we have to see their stool exam. If we see their stool exam and we need to give it, especially if it has dysentery, we can give it. The third reason is antibiotics may worsen outcome because some studies have shown that STEC and non-typhoidal salmonella, which worsens this case and makes them high risk to even have hemolytic uremic syndrome. Therefore, antibiotics are used primarily to treat severe infections, prevent complications in high-risk hosts like AIDS patients, and to limit the spread of infection. So the first line antibiotic is cotrimoxazole. It's active against a lot of the bacteria that we talked about, and then parasites like isosporia and cryptosporidism. But there is very high resistance against cotrimoxazole. So azithromycin is also being called as first line now. And second line, when we go there, it's cefixime, and we also give metronidazole if there's intameba, giardia, or C. difficile, especially if antibiotic-related diarrhea. So we are now in the era of prebiotics and probiotics. More, we're trying to not use antibiotics, but trying to stimulate our normal GI bacteria so we'll not get infected. So what are they? Prebiotics are non-digestible food components that promote the growth and activity of beneficial gut bacteria. Examples are the best example, and why we say exclusive breastfeeding is breast milk. In the breast milk, there's something called, now they found in research, is human milk oligosaccharide. It's a type of sugar that humans cannot digest, the children cannot digest it, but the good bacteria digest it and proliferate. When we come to foods, good examples are oats, banana, or onions, garlic, and the like. These are prebiotics, but when we come to probiotics, probiotics are live microorganisms that improve or restore the gut bacteria. Again, breast milk, by the way, is not sterile. It contains bifidobacterium and lactobacillus, which are good bacteria. And other than that, yogurt is a good example. There are also drugs that you put on water. They will be available soon. The pharmacologic people have told us that. Like examples are Saccharomyces boulardii, and they are effective in antibiotic-associated diarrhea and C. difficile diarrhea. There is some evidence that it might even prevent diarrhea in daycare centers. It reduces the incidence of necrotizing enterocolitis and reduces also duration of AG by 25 hours. So we have a patient with diarrhea. What are the complications? There are a lot of complications, but the major complications are dehydration, electrolyte imbalance, and acid-base imbalance, which are life-threatening. That's why when I told you when you manage diarrhea, the first focus you have to have is hydrating the patient. Then you go for the stool examination and the like. But first, what you have to do is assess the hydration status and start treating the dehydration. The other complications, especially if it's chronic, will cause malnutrition. And then the malnutrition itself will also cause diarrhea. So it's a bad cycle. intestinal perforation might also be there with amoebiasis, Shigella, and C. difficile. Intussusception might be there in viral AG because they will result in lymphadenopathy. Will have a leading point and they'll have intussusception. And then with bacteria, you'll see toxic megacolon, bacteremia, and sepsis. As I was telling you before, pseudoappendicitis will be there in Yersinia, and they are mostly treated by cephalosporins like ceftriaxone and Cefix. We can also have reactive arthritis, Guillain-Barré syndrome with Campylobacter, and UTI as well. So how do we prevent it? So for all the reasons I've told you about exclusive breastfeeding for the first 6 months prevents it by 12% of all deaths of children. Yeah, for children younger than 5 years of age. Vitamin A supplementation reduces all-cause childhood mortality by 25% and diarrhea-specific mortality by 30%. That's why we give vitamin A supplementation routinely to all children starting from 6 months, every 6 months, up to 5 years, as I was explaining to you. Rotavirus vaccine is also 40 to 60% effective, which is not very effective like the other vaccines, but it drastically decreases the severity and mortality. So we give it 3 doses now. There are also cholera and typhoid vaccines, but they are not routinely available. They're only given in outbreaks and military camps and the like. So another prevention is hand washing with soap, which can reduce the risk of diarrhea by 48%. Safe excreta disposal also can reduce by 36%, and 17% of reduction is estimated if you improve the quality of water in our country. So these are the key takeaways. Pediatric diarrhea remains a significant global health challenge, so we have to try our best to fight this as health professionals. We have to early recognize and give appropriate management, especially ORS, zinc, and IV fluids are very critical. Same patients, unless you counsel them very well, they think ORS ብቻ ሰጠኸኝ. ORS is very important, and they think ORS is not life-saving. So we have to give good health education for that. And then preventive strategies like giving vaccination, sanitation, nutrition is very important, and it reduces the burden. These are my references. Thank you. And if you have any questions for me.
Okay, thank you
I
very
hope
much,
I was
Dr.
not
Ahmed.
boring. This is a big topic. I try to condense it as much as possible.
No, I think the attendees also enjoyed the presentation. It was very short and precise, but it was very engaging as well. We have a couple of questions that we've collected from the chat box and Q&A. My
Okay.
colleague, Dr. Meron, is compiling them, and she just shared the screen now. So
Okay.
let us go through the questions quickly before we proceed to the post-CME quiz.
Yeah, so we had a lot of questions as much as possible where we try to answer a few of them. So the first one is effect of zinc under 6 months old infants.
It's mostly they don't have number one, we want them to be exclusively breastfed, so hopefully they're exclusively breastfed, and they don't have zinc deficiencies. Even in the formula they will have zinc, so it's not that much used. But if they have diarrhea, you still have to use it, but it's not common to have zinc deficiency in less than 6 months old.
Okay. So the next question is, how can we give rice water in children with diarrhea, and what is basic effect?
So you want my medical opinion or not? Because you'll make me fight with my mother, you see. If you want my medical opinion, rice water does not work, because we were saying inappropriate fluids, right? ORS is the best. Why is ORS the best? It has glucose in it, it has potassium in it, it has sodium in it. Yeah, it uses the glucose transporter effect of, because it has glucose, more sodium would even be absorbed, you see. So it's done in a way that's very scientific, and but I'm very it's if you study more about how ORS came to be, it's very efficient and patient-based. When we say rice water, how much rice? It might work. Herbal nagar, it might work. How much rice am I going to tell her to have? How much ml of water am I going to tell her to put? So it's difficult, and it has glucose. It's carbohydrate rice, but does it have the potassium and sodium effect that it's much needed? So I wouldn't recommend rice water.
Okay. The third question is previous guidelines stated that diarrhea in children under 5 years old is primarily caused by rotavirus and does not require investigation unless it's mucoid or bloody. So is this recommendation still applicable today?
Yeah, so rotavirus, as I showed you, still common because there are a lot of rotavirus types. And the vaccination is, I think, 4 or 6 now. It's becoming 6 or 8. So we still have a long way to go. But the issue is sometimes we have to adapt our the books to our cause. Yeah, their viruses are common, but bacteria is also common in our setup. Why is this? Due to our hygiene and lack of water. Water might not be there for a week, and when it comes, it's dirty water. Most of it is bacteria and amoebiasis. Yeah. So parasites are very prevalent in our country. So I implore you to do, if it's diarrhea that will resolve, you don't do stool exam. But if the patient already came to you, it means the diarrhea is bad. Yeah. So do stool exam for all. That's what I recommend. If the stool exam is normal, it means it's rotavirus. If as I told you, it's more than 5 leukocytes, bacteria is full, you see WBC and RBC, then you treat for bacteria. Especially in pediatrics, it's difficult to say what the cause is without investigating them. CBC and stuff might not be necessary, especially if they don't have fever. But I recommend to do stool analysis for almost all, especially if they came to you already and you have a good lab.
Okay,
Because again,
and
this the number 2 killer. Yeah, when something is the number 2 killer in your country, you have to overtreat. That's that. I might be wrong, but that's my view. You overtreat and save a life, because stool exam will not cost you a lot. Yeah.
yes. Okay, thank you and the first question is, so if a child has cycling vomiting, then can we increase the dose of ondansetron to 0.3 milligram per kg?
I think so. I'll have to check, but I think the maximum dose is 0.3. But how are you sure it's cyclic? Cyclic vomiting, by the way, I found a few cases, but it's a diagnosis of ruling out. You have to rule out every other diagnosis. After ruling out that, if you're sure, with closely monitoring, I think the maximum is 0.3, so I think so. But I'll have to check.
Yeah, okay. And the fifth one, they're kind of 2 questions, but I feel like they're on the same category. So in the IMNCI, clotrimazole was advised not to be given, rather amoxicillin and ciprofloxacin for dysentery. So, and the question related to that is, how do you consider the administration of ciprofloxacin for diarrhea as it's recommended by the guideline?
This is a good question. I left it out intentionally because but I hinted at it. Yeah, cotrimoxazole, everyone is taking cotrimoxazole, even for rotavirus infections. They don't do stool exam. Let's be honest, they go to the pharmacy, ask them about bacteria, no, cotrimoxazole. So there's a very high what's the word? ተላምዶታል ባክቴሪያዎቹ እና now advisement, if you see Nelson, and the like, is saying ciprofloxacin, azithromycin. Why I left out ciprofloxacin is there's only tablet. Yeah, if they're adolescents, you can give it. Yeah. In severe cases as well, if they're admitted, you can use the IV drip of ciprofloxacin, 10 milligram per kg. Yeah, you can use that. But if I tell you use ciprofloxacin, but in our country we only have the tablet, it's very difficult. That's why. But now, even for severe sepsis in neonates, we are using. We have our bacteria and susceptibility in research done in EPHI. Mostly they're susceptible to ciprofloxacin. That's why this recommendation has become there, because they're sensitive to ciprofloxacin. We can use ciprofloxacin, but again, how do you tell them to take tablet? That's why I left it. But you can use azithromycin syrup, which in Nelson is also first line with cotrimoxazole. And amoxicillin also, you can use amoxicillin, is fine for diarrhea. Amoxicillin, when you increase the dose, still works fine, but you have to make it 80 milligram per kg to 100 milligram per kg. Old books say 40 milligram per kg. That does not work because it's no longer susceptible to that. I
So the
hope
last question.
I answered your question. But you can still use ciprofloxacin, especially in above 6-year-old. They can take tablets, so you have, or you do it per kg, then do the tablets. Sorry.
Okay, thank you. And so the other questions we quickly wanted to address was regarding how you measure stool loss by weighing diaper. So because diaper can also contain the urine for both calculating the amount that we need for rehydrating.
Yeah, we weigh the diaper. You're right; it might contain urine, but that's the only option we have. We reduce 20 gram because the diaper itself is 20 gram, and then you weigh it. So urine is still output, yeah. Urine is output plus the stool gram you'll see, and that gives you the output. We're not only seeing completely. We cannot take the urine out because it's output. So we see the stool plus the urine, and we measure it, as you said, by diaper. We do minus 20 gram for the diaper itself.
All right. The last question is, how common is intestinal intussusception with the recent rotab vaccines?
I'm not sure. I've not seen such a case, but I'll check and read it. This is new to me. Has he seen any books like this, or I got no? Did you come across a case like this?
Okay, hopefully our participant who asked that question will type us the basis for his answer.
Yeah. What I know is not the vaccine, but the rotavirus itself, and norovirus, because they inflame lymph nodes. The lymph nodes itself will strangle the intestine, making it a leading point, and then it will become like that. But he said some books said that. I don't know. I don't know. Some percent might have it. I'm not sure. Maybe because it's a live vaccine and there's also lymphadenopathy. I'm not sure. I'll check and tell you. Tariq Hailu has a question. Dr. Meron, did you see it?
Yeah, okay. Let me look for
ciprofloxacin. There are a lot of researches done. Okay, only one research said they had a skeletal side effect. Other than that, there are like not hundreds, but a lot of researches, even randomized controlled trials that show that's not the case. Ciprofloxacin, even in neonates, we've used it a lot, but when we use it, it has to be the last resort. That's why I didn't want to mention it with myself here as well. If it's severe, you gave Cotri, you gave azithromycin, you gave cefixime, and it's not working, give ciprofloxacin. That's my advice anyways, because there was one research that says it's bad, but I think almost 10, 12 researches after that, long-term research showed that there's no side effect. So you can use ciprofloxacin. That's why in IMNCI, even in Nelson, it says ciprofloxacin treatment for AG. Any questions that we didn't address, Dr. Miron? Or we're out of time? Did they finish the quiz?
Okay, they have about 2 minutes to finish the quiz, but there was one question that we did not address. So it was about the drawbacks of capsule endoscopy.
It's expensive. That's the major drawback. It's expensive and not available. Other than that, it's safe, and instead of doing anesthesia, because you have to do anesthesia to do endoscopy, this one you just give it with water as a capsule, and then the system records on the computer, so you can follow them overnight until they pass it. But they have to be admitted in the hospital as well. You can't do it outpatient.
And another question that was on the chat box is rice, sugarcane, and whole egg are preparations that are useful to treat lactose intolerance, right? So can we say rice has the same effect on diarrhea treatment? I think it was raised earlier when we were discussing about rice water.
But not alone. As I showed you, it has to be scientific, right? I told you how much gram, how much this, how much that. You get protein from the egg, you get this from that. That's what I was trying to say. You can't say only rice alone. You have to give them how much they do, like I did it last time. The table, you have to tell them if they use the table, it's fine, because rice has the carbohydrates and the eggs will have the protein, and you have to balance it in that way, and then add glucose and stuff. Because as I told you, glucose is necessary to use the glucose transporter for the sodium.
And I mean, the last question that was raised, if we have time, is if a patient has a stoma, can we use a capsule endoscopy?
Sorry?
If a patient has a stoma, can we use capsule endoscopy?
No problem. It goes out the stoma. Normally, it will go out the stoma and you collect it.
So I'm gonna be sharing now the questions. Is my screen visible to you, doctor?
Yes.
Okay, so the first question is, what is the most common cause of infectious diarrhea in daycare settings?
So the answer for this is D, because I told you that because of small dose and high infectious rate, norovirus and giardiasis A and C. So the answer is D. Norovirus and giardiasis are the commonest.
Okay, the second question is, what is the most common pathophysiological mechanism of diarrhea?
As I told you, this is mixed type, because even, for example, rotavirus can have secretory type, it can have osmotic type, and also causes increased motility due to its toxin. So commonest mechanism is mixed type.
Okay, and the third question is, what is the most important aspect of managing diarrheal disease?
So the most important is hydration. It's the first one, and the killer is hydration, not the bacteria. What kills them first is the hydration, so you manage the hydration first.
All right, the fourth question is, which antiemetic has been proven effective in emergency management of vomiting in infants and children?
So the answer is ondansetron, as you saw. I didn't even include Plasil in it because in younger children, Plasil or metoclopramide doesn't work well. Ondansetron is the answer.
Okay, and yeah, that's all the questions that we have. Thank you so much, Dr. Ahmed. Dr. Simone, you can take over.
On behalf of all of us here at Yetena Weg and on behalf of our attendees, I want to extend our heartfelt gratitude to you, Dr. Ahmed. And it was a very insightful and engaging presentation. Your expertise and clear explanations, they have also, like, in a way, enriched our understanding of this very important topic. So we appreciate you sharing your time and also your knowledge with us. So thank you very much, Dr. Ahmed. If you have anything you want to say, let me give you the floor. If not, we can end the session.
Just thank you. It was also interactive presentation, so I'm happy to be part of the team, and have a nice night and weekend, Sunday.
Thank you very much, Doctor.
Okay,
Good night,
bye.
everyone.
Good night, everyone.